everybody. It's my pleasure to be here. I think I can say I've been on East Coast since Tuesday. I've been in Boston first and then now here, so I think I'm set with my yearly dose of cold, and I want to go back to San Diego. So what I'm going to be talking today, I'm going to go over current state of targetable lung cancer biomarkers, and then I'm going to concentrate on 3 of those biomarkers, primarily EML4 ALK, ROS, and RET. And if I have some time left, I will go over the HER2 insertion as well as the BRAF mutations. So by the luck of draw, I got to cover about this pie in about 20 minutes. The good news is that yesterday we covered PIK3 kinase mutation and FGFR, so I'm not going to go through that. So today I'm just going to concentrate on RET, ROS, EML4 ALK, and if I have time, I'll go over the HER2 and BRAF. So ALK, ROS, and RET have several commonalities in it. They are able to self-activating itself once there is a fusion between ALK or in a ROS gene or in RET gene. The part of the fusion actually involves the coiled coil domain, which means that the receptors can self-dimerize and activate and stimulate the cancer growth through the following pathway, which is RAF and PI3 kinase. RAS stimulates proliferation, PI3 and JAK-STAT resist apoptosis. The different oncogenes have a different proportion of stimulation through the different pathways, but overall the commonality of those 3 things is that they all can homodimerize without the need of use of the ligand, and they will be able to stimulate the cancer progression through the following pathways. When we were talking yesterday and today, there are 3 ways of diagnosing oncogenic driver. And I want to spend some time because I want to kind of make sure that we're all on the same boat before I go further and dig deeper into which test to use for each mutation. So I don't have to explain immunohistochemistry, which is very old test that we all know. I don't have to explain RTPCR, this is just a genetic sequencing, but I want to spend some time on break apart FISH because I want you to understand at the end of my talk why break apart FISH might not be an ideal test for some of the mutations. So in break apart FISH, you adhere 2 probes. One of them has a green color, another one has a red color to the gene. And if the probes are very close together, then the green will overlap with red, and the color that will be visible to your eye would be yellow. If there is an insertion between those 2 portions of the gene, which one has green, another have red, then those 2 portions will separate, so they will not overlap, and that's what's called a break apart FISH. So the signal goes from yellow to 2 dots. One would be red, another one would be green. So let's concentrate a little bit on the ALK fusion gene. So ALK fusion gene was first described in 2007 by Soda. It is interesting that the first patient ever described to have an ALK fusion gene was actually a patient with squamous cell carcinoma, even though we're not typically thinking about ALK fusion patients as a patient with squamous cell carcinoma, and it's impossible to say maybe that patient had an adenosquamous carcinoma and we just have to catch the squamous cell component, but the fact is the fact. The first patient ever described had a squamous cell carcinoma histology. So what happens, you have an ALK gene which gets fused with EML4, which stands for echinoderm microtubule associated protein-like, which creates a fusion gene, and that fusion gene has an ability to stimulate tumor growth in xenograft mouse models, as well as if it's inserted in the cell lines, the cell line will grow as well. So far, there have been 16 fusion variants described, and this list keeps growing. What's important here that even though we tend to think of ALK fusion gene as ALK fused with EML, sometimes it can be fused with TGF, or sometimes it will be fused with KIFB5B, which will go back to when we're going to be talking about RET oncogene. The significance of those fusion variants at this point is unknown in patients. What we know that those variants, probably because of the virtue of having a different length, have a different stability in the cytoplasm. Some of them disintegrate faster, some of them take longer to disintegrate. They also have a different sensitivity to ALK inhibitors, some of them more sensitive to ALK inhibitors than others. Again, this is all in preclinical data. And we also know that different variants have different sensitivity to HSP90 inhibitors. And I think Corey will be talking about HSP90 inhibitors later, so I'm not going to concentrate on that right now. So let's go through different method of detection. So as you know, FDA approved CRizotinib based on FISH break-apart test. However, FISH break-apart has some negatives. First of all, it's a very laborious test. You have to know what you're looking at in order for you to call the FISH break-apart test positive or not. The second thing, there was a pretty much arbitrary cutoff that was established saying the patients have to have more than 15% of the nuclei with split signal. You have to count 50 cells. So the question that I was what if your patient has 14% cells with split FISH probe? Do you call it FISH positive or do you call it FISH negative? The good thing about FISH that this is independent of paraffin-embedded tissue. The RTPCR, then the nice thing about RT-PCR, it is rapid detection. It will be able to distinguish each subsequent variant. And even though at this point we don't know what that means, I'm hoping that in the future we will know what that means. Because if you look at the patients who have an ALK mutation, who we give crizotinib, there are some patients who don't respond, and some patients who respond for a while, and some patients who respond for a very minimal amount of time. The problem with RT-PCR that it has to be multiplex. So you have to know the variant that you're going to be detecting. So if it's a variant that hasn't been described yet, you will not be able to detect it. Right now, people are hoping a lot for the immunohistochemical assay to hopefully become available in the US. We heard yesterday about Memorial Sloan Kettering using immunohistochemical assay. At this point, there is no immunohistochemical assay approved in the United States. However, in September of 2013, Ventana has received approval of immunohistochemical test for ALK positive in China. And that test looks pretty good compared to FISH, the sensitivity of 100%, the specificity of 98%. They tested 100 patients, and 2 patients who were immunohistochemically positive but FISH negative were RT-PCR positive. So technically, they did have an ALK fusion gene. It's just FISH missed that ALK fusion gene, but the immunohistochemical stain was able to pick it up. Ventana is running some studies in the United States, mostly with the second-generation ALK inhibitors, and one of the problems that they're going to answer is how is immunohistochemical stain will compare with RT-PCR as well as FISH. So EML ALK fusion gene, it says that the patients who have an EML ALK fusion gene are generally younger. They're non-smokers with adenocarcinoma. Sometimes they could have an adenosquamous carcinoma, and I did tell you the anecdotal situation when patients had a squamous cell carcinoma. It is not such a common mutation. If you take all comers, meaning smokers, non-smokers, the chances of a patient having ALK fusion gene is about 4%. But in EGFR negative patients, the chances of you having an ALK fusion gene is about 33%. We already covered that there are 16 variants. We don't know at this point what that means. The testing is a Weiss's break-apart FISH test, but there's some benefit of doing ALK PCR and immunohistochemical test, and the therapy is crizotinib. Why crizotinib? This is the data that was recently updated by ROS in Lancet Oncology. This is the patients who received a crizotinib, and 90% of them had some degree of tumor shrinkage, response rate of about 60%. The disease control rate at week 8, this is the time where the patient got their first scan, according to the clinical trial, was 82%. The median time to response was about 8 weeks because that's where the patient got their first scan. We actually published a report of a case report of a patient who had a response at 2 weeks after starting crizotinib, dramatic response in the tumor. The median response duration, so what I would expect from ALK inhibitors is to actually work for nearly a year, so about 9 months to about 12 months. What we don't know about crizotinib is how does that compare to chemotherapy in first line. We do have some data on second line, but we do not have a data on the first line. So if you remember, the FDA approved crizotinib without the mentioning of line of therapy. If you compare, again, this is a cross-trial, cross-mutation comparisons, but if you compare how the crizotinib behaves in patient with ALK fusion gene and how erlotinib behaves in patient with EGFR-sensitive mutations, I think one can make a leap of faith and use crizotinib in first line. The Profile 107 study compared crizotinib to second-line chemotherapy. The choice of chemotherapy in second line were either docetaxel or pemetrexed, and it showed that progression-free survival is 7.7 months in crizotinib versus 3 months in chemotherapy, highly statistically significant. Response rate was higher in crizotinib. Overall survival wasn't different because 64% of patients who received chemotherapy later crossed over and received crizotinib. What's most important, I think, here is that the quality of life was better in a patient who were receiving crizotinib. And there is a study called Profile 1014 who will compare crizotinib to first-line chemotherapy. This is a Kaplan-Meier curve of progression-free survival, second-line chemotherapy compared to crizotinib. And this is your quality of life indicators. You can see that the global quality of life improved if you were randomized to crizotinib, but decreased if you were randomized to chemotherapy. Overall, the symptoms improved if you were randomized to crizotinib. The chemotherapy only resulted in one improvement, which is cough. The rest of the symptoms got worse on chemotherapy. And this is time to new onset of symptoms, and crizotinib did better compared to chemotherapy. So crizotinib not only improved the symptoms in patients, but also delayed the recurrence of the symptoms. So the one thing I want to spend on today is progression. We've heard, I think it was Gregory Riley who did some talk about progressions in patients who have a sensitive mutation who received erlotinib. The same thing happens here. So the progression in the patients who receive crizotinib could be slow, could also involve the single site. Kamich published a study where he allowed the patient, so the original crizotinib study allowed the patient to continue crizotinib post-progression. So Kamich published the data, and there is 39 patients who received crizotinib beyond progression, and 12 of them received crizotinib for 6 months. The range of post-progression therapy was about from 21 days to nearly a year and a half. The most common sites of the progression was brain, lung, and liver. This is a graphic way of representing the same data. So this is the patients who were entered into the crizotinib. They are grouped based on the response. So in blue here is a patient who progressed. In red, here are the patients who had stable disease. In green, those are the patients who responded. The shaded versus striped graph. So this is the patient, let's say, who started on crizotinib. They have stable disease. Right here, they progressed. Progression was slow, progression was minimal. The patient continued on crizotinib, and he was able to continue on crizotinib for nearly, I think, about 300 days more until the physician felt that, okay, this is enough. The patient is starting to lose quality of life, and at this time, the decision was made to stop the crizotinib. This is the longest patient, the first green graph. This is the longest patient who remained on crizotinib post-progression, and that patient stayed on crizotinib for 561 days. So we now know the mechanism of crizotinib resistance, and what I want to concentrate on here is that crizotinib resistance can be two ways. You can develop a secondary mutation very similar to EGFR mutated patients where they develop a gatekeeper mutation which renders crizotinib not effective. But it's interesting, there are some people who actually develop a different mutation. So the patient can have a de novo EGFR mutation which kind of bypasses the signaling through the ALK, through the different pathway. They can have also develop a de novo KRAS mutation. They didn't have KRAS mutation, but KRAS mutation developed on crizotinib. So how do you manage patients with crizotinib resistance? If your resistance is local, meaning just one site, I think it is reasonable to do aggressive local therapy. We've gone as far as resecting sites of progression, but usually we do radiation. You can also give them platinum-based doublets. There is some data that pemetrexed works better in patients with crizotinib resistance, or you can give them a second-generation ALK inhibitors, and there are 3 drugs which are currently in the market, and I think Corey will cover HSP90 inhibitors. So there is life after crizotinib, and that's kind of the title of this slide. The LDK378, which is currently in phase 2, The phase 1 showed that there is a 58% response rate in patients who develop resistance to crizotinib. Chugai compound gives you about 48% response rate, and Ariad compound gives you about 76% response rate. The most important thing that all of those three compounds have a CNS penetration. So if your patient develop recurrence on crizotinib in the brain, if it's one recurrence, you can do stereotactic radiation, but if it's a multiple recurrence, there are options that are available to you, and the trials are actively accruing, and there are several sites in the US. So the next I want to concentrate on oncogenic ROS. So ROS is a fusion gene that was first described in glioblastoma, and it fuses with FIG, which stands for fused in glioblastoma. It is a deletion on a chromosome 6. It has two isoforms. It has been shown to induce cancer in mice model, as well as induce growth of cell lines. ROS has been also described in cholangiocarcinoma, ovarian cancer, gastric, colon, myofibroblastic tumors, and angiosarcoma. This is an example of one of the ROS fusion genes where the ROS kinase fuses with EZR, creating a fusion protein. The ROS is slightly different because so far we have, there is about 9 variants have been described, and those keep popping up pretty much every month. As I was preparing the slide for the talk, there is one more fusion variant has been described. And that makes it different for us to detect ROS with RTPCR, because again, as I mentioned before, if the fusion fragment is unknown, you can't detect it because you won't have a primers for that. We do not know the significance of different ROS fusion genes. The commonality between ROS and ALK in the patients who have a ROS fusion gene are usually younger. They also never smokers. They have an adenocarcinoma. They have been described to have a high-grade histology. The incidence of ROS fusion gene is about 1.2 to 1.7. We already talked about 9 variant. In ROS, right now, the best testing would be to do a break-apart FISH. Immunohistochemical stains look pretty promising, but it hasn't been validated enough, and RT-PCR at this point, I would not think it's a good idea. So in order for you to test for ROS, I would recommend for you to do a break-apart FISH, and I already covered that. So this is an example of, since ROS fusion gene is about 50% identical to the ALK fusion gene on the tyrosine kinase domain, people have thought that maybe trying crizotinib will work, and it did. This is a case report which was published in JCO. This is a patient at baseline. You can see a lot of disease in the lung, and this is about 12 weeks on crizotinib. The patient did have ROS fusion gene. So this is another publication, 14 patients presented by Alice Shah in 2012, and you can see that 14 patients with ROS fusion gene, and out of those 14, about 7 half had partial response, 1 had complete response. The minority of the patient had either stable disease or progression. So RET fusion gene. In RET fusion gene, this is a novel gene that was just described literally a year ago. What we know so far is a very new area. What we know so far that immunohistochemical stains will not work in RET fusion gene because they do not correlate with the fusions. Right now, you can do either FISH or you can do RT-PCR with the same caveats that I already mentioned for the FISH and RT-PCR. So far, there have been 3 fusion genes described, and I would not be surprised if the list will grow further as we study that fusion gene more. Very similar to ROS and ALK, this is also patients who are never or former smokers. They usually have adenocarcinoma and adenosquamous carcinoma. In the patients with early stage disease undergoing surgical resection, it has been noticed that those patients have an earlier lymph node metastasis. Frequency depends on how you prioritize your patient. So if you take everybody, the incidence is about 1.4%, but if you have a patient who is negative by 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Negative for 10 oncogenic mutations, then the chances of them having a RET oncogene is about 16. So it's all about how you, what kind of selection do you use to do the test. Right now we have 4 variants. Clinical significance is unknown. At this point, people would do either FISH or RT-PCR, do not do immunohistochemical staining. The therapy at this point is unknown. There are 5 candidates, which is all of them have activity against RET mutations. 3 of them are approved in thyroid cancer, and 2 of them are approved in hepatocellular carcinoma. All of those drugs have activity against the fusion in cell lines, and 4 of them are in formal clinical trials. This is a case series reported by Drilon in a patient who have a RET fusion gene who received CRizotinib, and this is the difference between scans is 4 weeks. So you can see patient A had a response in the mediastinal lymph node, patient B had a response in the primary lung, and patient C is the only patient who had a stable disease, patient that have like a lymphangitic spread mostly rather than measurable nodule. So this is a table comparing those ALK, ROS, and RET, and you can see that the dates that have been discovered, you can see the frequency, it's pretty rare. You can see the treatment, crizotinib versus crizotinib, and a slew of other things. The carboplatin trial is accruing. There is a site on West Coast and a site on East Coast, and the ponatinib trial also accruing, and I don't remember where the sites are. So I have 2 more slides. So HER2 insertions, rare. Usually happens in never smokers. It's usually an insertion in 20. We do have confirmation of oncogenicity in transgenic mouse models. The drugs that are being considered for patients with HER2 insertions are neratinib, afatinib, dacomitinib. There is some preclinical model that shows synergy with mTOR inhibitors, and there is actually reports of patients responding to combination of neratinib and temsirolimus. There is also some case reports showing response to afatinib and dacomitinib in the patients who have an insertion 20. My last slide is about BRAF mutations, pretty rare. The BRAF mutations in lung cancer is actually quite interesting. They're not as uniform as in melanoma. In melanoma, we know that majority of the BRAF mutations are V600E. In lung cancer, V600E is only responsible for about 40% of mutations. And there's a difference between your smoking history. So if you are a non-smoker, you are more likely to have V600E. If you are a smoker, you are more likely to have a non-V600E. There is a case report of a patient with V600E responding to venfrafinib, and the brafenib is currently being tested in patients with V600E. In the patients who do not have a V600E, there is some benefit or some rationale in using MEK inhibitors.